So our first speaker today is Luc Puis. He is a perfusionist from Belgium. He was a liaison to the ICBP and co-chair for the 2019 EATS guidelines on cardiopulmonary perfusion. He is also the author of the Tiny Perfusion Letter for all of you that subscribe. So today he is going to be speaking on the European ECMO experience with COVID-19. Thank you, Luc.
Thank you for a nice introduction. Let me share my screen. That looks all right. So thank you, Carla, for the nice introduction, and thank you for giving me the opportunity to talk to you about this European ECMO experience with the patients on COVID. And I don't want to say I'm the expert in ECMO, and certainly not in Europe, but I'm just taking a look at the numbers and keeping an eye on what is happening around here. And so I want to report on that and give you my personal opinions as well. So, yeah, I have no conflict of interest to declare regarding this presentation. And the outline of my presentation will be in three parts. I will talk a little bit about what's happening in the literature very shortly, because there's tons. Discuss some of the registries that are there. Then I will go deeply into the situation that we experienced in Belgium, and then take it, expand it to Europe, and then compare it to the USA and the rest of the world with the ELSO registry. And then I'm going to just briefly touch on some observations that I made during what I saw clinically and what I saw in the literature regarding some of these subjects that happened. So if you want to know how do I treat my patient on ECMO, then with COVID-19, then good luck, because there's a massive explosion of literature on COVID-19 alone. This is from April 11. Sorry, the date is in European. From April 11, and in 2020, this bar there was more than 190,000 publications. And in 2021, we already are at more than 40,000 publications. And that means that around every 3 minutes, there's a publication about COVID-19 somewhere. So it's really hard to find and to dig in the literature. But there are some publications that are worthwhile, and I will share you some of those later. So in the beginning of the pandemic, and that was even before Sanibel 2020, there were reports, the first reports of people that were put on ECMO in China were really bad, and they were there was a high mortality, and that was probably because there was not enough knowledge around the disease and the treatment of these patients. And this led to many people saying that that ECMO for COVID would be a futile therapy, and we should keep it for patients that were actually worth putting on ECMO. And many people advised against it, but of course there was not much alternative, in fact. And this is another publication from that time, March-April 2020. From Mexico, where they recommend to not put patients on COVID-19 because there's a high mortality. And so, despite all these negative reports in the beginning, there was no alternative, and people were actually suffering to get cured, and with low PO2s and low saturations, and so we prepared anyway for COVID ECMO wave. And we started looking for materials and hardware and software and disposables. Sorry, and this led really to preparing ourselves for an ECMO wave. And the waves have come. That we've all seen that. And this has led then later to the first recommendations from the ELSO, not really based on much knowledge or evidence, but nonetheless, they try to guide perfusionists and ECMO and carers for ECMO patients all over the world with some recommendations that were really useful and could help us in providing care to the patients. Now there's a lot of talk about the pathophysiology of COVID. There is what we can say is that the disease is very complex and plays on many levels of the body systems. Not only infectious, but the infection leads to a high inflammatory response, and the inflammatory response leads to a lot of coagulation disorders and endothelial problems. And it's not easy to know which patient is going to react in a certain way. The disease is very unpredictable and can be really problematic in some cases. But obviously, I don't have to tell you all that because you know that. But if I would recommend something that is very useful to read on ECMO or COVID-19 and the pathophysiology and how it affects the coagulation system, I would recommend this article by Dr. Magnani. And it's a really extensive description of what happens when patients get COVID-19 and how it works on the different levels of the different systems in your body, and with a special emphasis on coagulation. And he uses this scheme or this figure to try and describe how just the COVID-19 infection works on the different systems and how it affects all of these body functions and coagulation systems. And you might see that there's a lot of these syndromes or factors that we see here are very common for us, because there's another thing that also plays a role in all these things, and that's cardiopulmonary bypass or extracorporeal circulation, for that matter. And we see a lot of problems sometimes with endothelial damage. We know that there's endothelitis sometimes with cardiopulmonary bypass, stasis of blood. The platelets and the monocytes get activated. We sometimes see HIT patients. So there's a lot of interplay, not only from the point of view from COVID, but also if we interfere with our systems, then we play a role in that as well. And it's not always easy to know in which stadium the patient actually is in the disease. So which thing should we treat first, or what can we rule out to make the patient better? So it's a very complicated thing. And this slide was from another presentation of me. So we're not the only culprits. It's also when you saw a patient in half, when you open his sternum, you activate him, of course, you get a reaction. And the only discipline, ICU and anesthesia, are actually the only caretakers that actually do something better for the patient. And as an anesthesiologist always told me, anesthesia is good for the patient, and I think she was really right this time. But anyway, this is just to show how complex it is and how difficult it is to gain knowledge, because there's a lot of things coming out. And then there's also registries and surveys that we see appearing. Of course, there's the ELSO registry and the Euro ELSO registry, which were already existing, but they really did a great effort to pick out the COVID-19 patients and to gain information, to share also the knowledge. And I think there's been a few recent publications that are really detailed in what's happening with these patients and the blood values. And I think from now on, we will see a lot of reports from these registries. I will touch briefly on the genomic trial, the ECMO card study, and the Generate project. because I know that a lot of way smarter people than me have talked about this and described this. So I'm going to touch them briefly. So the ELSO registry, so it's called the full COVID-19 registry, and you can all find this data on their website. I'm sure somebody has talked about this, but we see that there's a whole lot of patients that have been put on ECMO all over the world, and the greatest number was in North America, but we see a lot of European centers contributing the ELSO as well, and we will see that this is only a small cohort of the Euro ELSO patients. And then I don't know if it is because there are less ECMOs or because they report less, but the contribution to the Euro ELSO registry, to the ELSO registry, excuse me, is a little bit less, but I don't know what causes this. Then the Euro ELSO registry is in fact the same as the ELSO registry, but what they did was as soon as COVID hit, they set up a survey especially for COVID-19 patients. And what they do is they have a weekly roundup. Every week they gather data from the centers that contribute, and they send out reports, which you probably will have seen on Facebook or LinkedIn or other or Twitter or something. And I've taken a look at the current situation on April 12th, so almost a week ago. And there's 191 centers from Europe, from 22 countries contributing. And at this moment, there's 3,900 cases that are being followed, of which 500, a little bit more than 500 are still ongoing. And of those patients that have stopped, like 3,900 minus the 917, excuse me. Of those, 1,800 were weaned, so 53% were weaned, and then almost 1,600 patients died on ECMO. So that's a high mortality for mostly VV ECMO. And then the Euro ELSO survey also reports 122 patients dying after weaning. So overall, the mortality, if you are put on ECMO for COVID-19, is exactly 50%. And we will see later if this correlates or is in accordance with the other registries. So that's a 50-50 chance of survival when they were being put on ECMO for COVID-19. They also report on the configurations that are used. So 9 out of 10 are VV ECMOs, and then the 5% are VA, and others can be VAV or VVA or ECO2 removal, ECHO patients. And then we see a mean age that is around 53, and 4 out of 5 patients are male that are being put on ECMO. That's some of the information that you gain from them that they send out every week. So this is, for example, from LinkedIn, but you can find it on their website as well. It's an overview of all the centers contributing with the numbers. For example, France has on April 12th, they had contributed 535 ECMOs from all these centers. And it gives you a little bit of an overview of what is happening in Europe. They also give a trend. They also give some trends. These are the actual total numbers of ECMOs that have been reported from, but this is only the second wave, September till now, till April, September 2020 till April. Yes, these are the participating centers, so it's still growing, which is a good sign. We have the ongoing ECMOs, the patients that have been weaned from ECMO, and the disease trend either on ECMO or in the little gray bars, the deceased after weaning. So you can really follow up what's happening in Europe with regards to the numbers of ECMO patients. And also every week they give the trends for the mean age and the percentage of male, female, and also the configuration. And I must say that that trend has not really changed over the whole of the reporting cycles. So it's been pretty much younger patients, and 4 out of 5 are male patients, and most of them are treated with VV ECMO. Then very shortly, the ECMO card study is something that is happening. Not only, it's not really in Europe, but I just wanted to touch on that. And this is just this study was started up to make sure that every COVID-19 patient and the treatment was recorded and reported. And I'm pretty sure that soon enough we will find some publications from them. And you've probably seen these nice infographics from can't remember her name now. There she is, Miss Fella Antonini, and she really, is publishing this and keeping us up to date with what is happening everywhere. Then there is the Generate project. I think someone spoke about this, Justina Swol. I saw it passing in her presentation, and this is just trying to locate all the European ECMO centers and trying to analyze whenever there is another pandemic, if we have where the availability of the ECLS is, and where we can send patients, because I'm not showing it in this presentation, but it's from the literature. It's become clear that the more you centralize care, so the more centers have patients, the more patients they have per center, the better the care is and the better the survival. So that's something important, and I think the Generate project will contribute greatly to this. And then just for the information, the Genomics Project is basically looking. It's been an ongoing study. It's a global effort to trying and understand how people are being treated and how critical illness works, with an emphasis on genetics, because we see, for example, for COVID as well, that genetics play a very big part in how the body reacts to the disease and how the inflammatory response is aggravated or not. And so they already had a survey, a registry, so they work together now with the Asian Pacific ELSO community to reach out for those, to look at the patients that are for COVID-19 that are put on ECMO, veno-venous ECMO. So also probably soon we will get some results from that as well. So what is the situation in Belgium? We're going to the part where we look at how the situation is in the different sides of the world. Belgium is a very small country, only 11.5 million people live there, but we have a lot of cardiac centers, too many, most people say, but it's a political issue. And we don't know really how many ECMO centers there are. There are 15 reporting to the Euro ELSO survey, but there is no mandatory reporting for ECMO centers. And so some non-cardiac centers also perform ECMO, but it's hard to put a finger on it. So we have no statistics on the number of ECMOs yearly. I found some reimbursement website that talks about 515 ECMOs in 2019, so pre-COVID, and now we are probably way above that number. But what we do have, and that is a very nice tool, that is since March 2020, all the hospitals have to report daily to the government with regards to how many patients with COVID there are in their hospital, how many are on respiratory support, how many are on ICU, and how many are on ECMO. So that's very convenient. And I've pulled out the numbers for you. And you can clearly see the 3 waves that we have experienced or are still experiencing. So this is the total of the hospitalized patients only in Belgium. And so we start in March here, and we have our first wave, which was like really shocking us, and this was the worst we've seen. And then by June, July, it calmed down, and we had a relative calm summer, but we still had restrictions, although we tried to reopen a lot of things. And then, although they had warned us that it would happen, we were still shocked that by October, the numbers were going up again, and we experienced a very hard second wave that lasted at least until January, but is still ongoing. In fact, it never calmed down. And now we are experiencing a third wave, which is really, it's getting hard to suppress that wave, to keep it down. Because obviously there are some variants. Our vaccination has gone a little bit on the slow path, but it's gaining speed now. And lastly, the people are really sick of being restricted, and there's a lot of I would say protest, but the people are getting tired of it. So that's also a huge problem to try and stick to the limitations. Then projected upon that, and please be aware that the dark number is the patients in ICU, but the scale is different for the dark scale. So, but it follows nicely. Number of people in ICU almost similar. We're trying to get them down, and they are slowly going down, the numbers on ICU, but it's a daily follow-up. And if we look at the number of patients that are being on respiratory support, then we had a higher peak at the first wave, and it was better. We had better knowledge of how to ventilate patients or how to avoid to ventilate patients, and I think that reflects here in the slighter lower number of patients being on ventilatory support. But if we look at here on the red line, the number of patients on ECMO, that is for every day. So the first wave, the highest number was around 48, I think, patients on ECMO on the same day. And the second wave, we put a lot more patients on ECMO. Excuse me. So we were almost at 9. I think the highest number was 93 or 96 patients on ECMO at the same time, and that is really something that we've never seen in Belgium before. Like probably like in most other countries or areas. And then we were actually going down, but we always follow the wave, and this time we even preceded the wave, so we have less people on ventilatory support. Well, not less people, but the number of people, the percentage of people that had to go on ventilatory support was lower than the percentage of people that went on ECMO, because we see really the third wave in severity of disease is even harsher than the second wave. We really see very, very sick patients. They're also younger, so they react. They have a higher inflammatory response, so that's really, really bad numbers for the moment on ECMO. And they're really, actually, still, I was in the hospital yesterday, and there were still patients coming in and going out and getting off ECMO, and they're mostly very young, probably because most of our older people are vaccinated or have died in the previous waves. So, and if we look at the European numbers, and these are the ongoing cases, so we have the same first wave, and then during the summer it was relatively calm, although the numbers were still high. And then in October, the second wave started, and it has never subsided. They speak now about the third wave, but the third wave is actually the same as the second wave. And I think you can see this is the reflection of the variants the British, the South African, whatever country they originate from. This is what is reflected here, and also probably because patients are not, because people are not paying attention anymore to restrictions. Okay, so I'm not going to go deeper in this. If we look at the different countries in Europe, then we see that, for example, France, Germany, and the UK, they have a high number of patients, but a low number of centers. And that means that the average number of cases per center is higher in these countries, and especially in the UK, where they have, like, for the same population as, almost the same population as France or Germany, they have like way less centers, only 6 centers, and they really are centralized. And we see in the literature that is very important for the outcome of the patients. If we look at Spain, which has only like 1/3 or half of the Germany or France population, they have a way higher number of centers, just like Italy, Belgium as well, and we have a lower number of cases per center, which we should try to avoid. In fact, Russia is a little bit an exception. They have a lot of centers, but this is a huge country. You know, if you talk about USA, they have 4 time zones. Russia is spread over 9 time zones, so they have a huge distribution of people, and they have some centers that have a lot of cases, like the maximum is 61, and then half of their centers, the median is 2, so half of their centers only have 2 or less patients treated. So there we see the difference in how the care for the patients is decentralized or not in different countries. So to conclude, for the situation in Europe, there's no centralized reporting. Also, the management is decentralized, like there's no EU management, or everyone has to take care of their own, is able to take care in the way that they want for ECMO patients or COVID patients, which is, in my eyes, a problem, I think. But there is a strong collaboration nonetheless. You can pick up the phone and call someone in a center that has a lot of experience and ask him, I have this patient, or I have this problem. What do you recommend? But there are no statistics on the actual number of ECMOs or the specifics. And I think that if you are a center that wants to do ECMO, then it should be mandatory to report your outcomes and your numbers. But that's a different discussion. And this is a great opportunity to prepare for the next pandemic, because it's not a question of when, it's not a question of if it's going to happen, but when. Now, I'm almost done. The situation in the rest of the world, I've showed you these numbers from the ELSO registry, and it's very hard to know these 1,474 patients from the Europe, if they are included in the Euro ELSO survey or not, or if they are only in the big ELSO. So there is a little bit of a miscommunication between the different continents. And once again, a lower number of patients from other countries. But if we look at the statistics, and I've taken this from the website, the spread in this is ELSO, so a bit of Euro ELSO and North America, and then the rest of the world. And this is Euro ELSO, so only the countries in Europe. And we see that there's a little bit more males in Europe being put on ECMO. The age is a little bit older, but not really. I don't think that this is statistically different. And the distribution, we have a little bit more respiratory ECMOs, and this is also a difference in just the terminology. We speak about VV, VA, or other, and in the US it's respiratory, cardiac, or ECPR. And also in America they talk about the status post ECMO, and we talk about weaned. But we can clearly say that the mortality is overall is the same between the different registries around the world. Then, as I told you, we have very sick patients, some of them with many comorbidities and a high mortality if we put them on ECMO. It seems like there is a higher need for anticoagulation, or we might need to switch to alternatives, or maybe suppress more the inflammation. There is a tendency to have a faster oxygenators change out or system change out, but it's not sure what markers we should use to make that decision. There is a switch to a more ICU management, certainly in Europe, and maybe that is what is causing this change. And well, the outcomes, is there still room for improvement, or is this the best that we could do? So maybe the genetic profiling can be an answer to that. And this is a picture that I took this week from a pump that we took out of a patient. And as you can see, there's a clot within the pump, and this is the kind of complications that you can encounter in ECMO patients, of course, and everyone is familiar with that. And then there's going to be, I think, in the near future, a lot of publications about coagulation and inflammation markers, and how we should interpret them and what it means for the patients for the outcomes. And then this was just as an example of a report from a group. This is mainly the Netherlands, Belgium, and then a center in Sweden and a center in Spain, I think. And they looked at 71 ECMO patients with COVID-19, and as you can see, the distribution is the same: 93% VV, and the rest veno-arterial or other. And what they see is that the number of mechanical thrombotic events, for example, is around 14%, and I think the ELSO registry talks about 15%. So there is a high number of complications, not only bleeding but also thrombotic events, of course. And these are the kind of reports that we will see soon. And what they did was they took 71 COVID-19 patients and they compared them with 48 non-COVID ARDS patients. And they compared not only the patients, but also the complication rate, and they couldn't find really a big difference between the complication rate and the mortality between the two groups of patients. And so they concluded that and you can see here the survival curves of both the light blue is COVID and the dark blue is non-COVID ARDS, and it's just similar at 100 days mortality. And so to conclude is that that is not only their conclusion but also my conclusion of the talk, is that ECMO is still a useful and a life-saving in COVID-19 patients. I think we should not stop doing it, but we should probably look at the indications. And it's a complex, unpredictable, and difficult patient profile that we are having, with at this moment a 50-50 survival rate. We have to learn the lessons for the next pandemic. Is that we have the databases, but we should do some research on specific topics and try to get the specifications right, the nomenclature of what we say, not only respiratory, but we say VV or VA. We have to make some decisions on that. There should be a little bit more cooperation between continents, probably, but they're all working that out. We can learn to make strategic plans and centralize ECMO. That's one of the key things that I think is important. And we should look at staffing and resource utilization, but we can fill up a whole day talking about that. So thank you very much for your attention.
Luc, thank you so much for joining us. That was some excellent information. Thank you for sharing. We have a lot of comments and questions in our chat room. One of the ones that we've heard a lot this entire week is about CytoSorb. Do you have any experience with CytoSorb? Did y'all use that in your ECMO patients? Did you see a difference if you did?
I haven't used it, and I haven't seen it used. Mm-hmm. And I'm personally, I think the CytoSorb is something that is useful in some cases, but I would not use it as like, okay, it's a COVID patient, he has to go on ECMO, so we're going to put in a CytoSorb filter in it. I don't think that's very useful. And the CytoSorb filter is not selective enough, I think. It takes away the bad cytokines, but it also takes away the good cytokines. So, and I don't think it evens out each other. I think for a part, you also do a bit of harm, but that's my personal opinion. But I'm still waiting for the first. There have been some reports, but there's no useful information on outcomes because I think it is not the only thing that it's not like the golden egg that or how do you call it? Like that will cure the patients if you know what I mean.
I do. And the other question that they really wanted to know a lot about was how do you anticoagulate? Bivalirudin, argatroban, heparin, and how do you choose?
Here in Belgium, I think it's mostly still heparin because we don't really have a good experience. No. Not enough experience. I don't say the experience is bad, but we don't have enough experience with the alternatives. Although I think from a personal level, it's interesting to see that there are less complications. There was a report recently comparing heparin to bivalirudin for especially ECMO COVID-19 patients, and they reported better outcomes or less complications at least. I don't think there was a difference in mortality, but if you have less complications, then I think it's worth trying. One factor that we have to keep in mind in Belgium is the reimbursement. So if it's not reimbursed, we are more probably not using it.
So bivalirudin is not reimbursed, or argatroban?
I don't think for these specific cases. Okay. I should check, but we have a very low reimbursement for ECMO as a whole. Like
that was one of the questions that was popping up is what was the reimbursement for ECMO over there?
Yeah, so we like Belgium is next to Germany. In Belgium, we have for a VV ECMO, I think it's 1,000 euros, which is about $1,100 for a ECMO, and you have to put in everything. You have to put in your console, not the console, but the oxygenator, the pump, and that is for 5 days or something. And then if you go over the border to Germany, there you get 20,000 euros for an ECMO.
Wow.
So yeah.
Big deserves for me. Well, thank you very much. I know everybody's wanting to ask questions. So, Bill, you want to jump in?
Yeah, sure. Luc, excellent presentation. And thanks for summarizing information that is still coming through. I noticed a lot of the questions that are coming up in the chat session, and there are many, have been covered in some of our previous talks that we've had throughout the meeting. So I would encourage, because of time-wise, I would encourage many of you, if your questions aren't answered, to go back to the Sanibel 2021 YouTube recordings and go look at some of those ECMO sessions as well. because many of those have been covered, although I'm sure Luc could answer them if we have time to bring them up again. Luc, what I've found is it's interesting, first of all, that I see that survival rate versus mortality. Some speakers or some societies speak in mortality, where other report in mortality, where other societies report in survival. And sometimes it seems like that gets mixed around. Fortunately for us clinicians with COVID patients on ECMO, the mean falls right in around 50%. So there's not a huge difference. On the other hand, I've seen centers, or watched centers that are 10% survival versus 80 or greater than 80% survival with COVID patients on VV ECMO. I want to know, I think it would be great to address that. And I have an opinion on that too, but I'd like to know your thoughts on that.
Yeah, thank you. Thank you. That's a very interesting thing to know. Like, for example, we had the webinar with the Joint Perfusion Task Force, and we saw the excellent results from that center in New York. And it's all about indication, because I think if you would take all the patients that were presented to that center, and if you look at that mortality, that would be, it's not fair to do it, but I want to say if you reject certain patients, then your figures will be higher, and that is exactly what the difficulty is. They spoke about at one point they rejected a patient that was pregnant and they didn't want to put her on ECMO, and I'm not judging that. That could have been a good decision, but we don't know the outcome of these patients. Did they survive or not? And in Belgium, it's very, very difficult to decide to not put a pregnant patient on ECMO. You want to avoid that, of course, but if there's no alternative, then you have to do it. And I don't think anyone would reject putting someone like that on. So the difficulty is that the numbers are different, but you would have to have a risk profile of the patients that you're putting on ECMO. And then you have to use scores to know if it is, still worth the while. Because maybe you can put someone on ECMO and he or she will die, the patient will die, and then you would say we shouldn't have done it. But sometimes you put someone on ECMO and at the moment you put them on ECMO, you're like, okay, this is not going to work, but then they survive, and you don't want to miss those cases either, And then a second thing that is important is that we don't have any reporting on longer term outcomes. Like you can say, oh, our patient survived and he left the hospital, he or she left the hospital, but is spending the rest of the summer in a revalidation, and the rest of her life sipping at a straw and not having contact with anybody, And we don't see that enough. We only see the patients surviving ECMO and then going home, but we don't see the misery that is accompanying those people.
And it's not like we're not trying to capture that in some reporting. There just hasn't been that time yet. I mean, this has all been going on with COVID patients just for a year. I would also add that there would be criticism on programs that might be a little bit more aggressive on putting an ECMO patient, a COVID patient, on ECMO sooner rather than later, so that the patient isn't exposed to the deleterious effects of mechanical ventilation for longer periods of time. So the critics would say, well, they put them on earlier, so maybe they need to go on ECMO. Well, we've heard that same critic throughout the evolution of ECMO, but maybe it is wise to put them on sooner, to get them off sooner, so that they have a healthy life and they don't have the problems of barotrauma and the other pathologies related to mechanical ventilation in the long term. So it's an interesting topic.
Yeah, it is. And also you can maybe avoid ventilating patients by putting them on ECMO. and look at it the other way around.
And I think Dr. Brody talked about that eloquently on the first day on that changing paradigm, first day of the Sanibel program. So I see that as the future, actually.
Yeah.
Thank you.
Yeah, sure. And I sorry if I don't want to go through with this, but it's not only for COVID-19 patients, it's for every patient you put on ECMO. You know, the ECPR patients, you can have an outcome, dead or alive, but what does alive mean? You know, is it quality, or it's just spending 6 months on ICU and then dying anyway? So
yeah. What have you seen the average time? I'm sorry, Brian, but what is the average? I didn't see you speaking. What is the average time on ECMO that you've seen? I know Al Stammers, with his data in the AMSEC webinar, reported about 19 days with patients that were in the care of his company with specialty care. 19 days on VV ECMO with COVID patients. Have you seen differences in that? And if I missed that on your data, I apologize.
Yeah, I didn't report on it. It was somewhere in the last report I talked about. It said it, but I don't know by heart. But I think 19 days is pretty much the average that we can see here as well. It's patients can spend 3 to 4 weeks easily on ECMO before they are taken out, before they are weaned.
So that's interesting, because I think a lot of ECMO programs, they think, well, if nothing's happened in 2 weeks or so, maybe terminate the patient. But you're talking about the average of 19 days, and that's with a greater than 50% survival. So I think that patience is a virtue here, unless, of course, the comorbidities and the neuro status has been deteriorated to a degree where there is no hope. But there are limited resources. And I remember, like back in the congenital diaphragmatic hernia days, we were taking patients off in 10 days. Later, they were dying, later learning that it was 3 to 4 weeks sometimes that patients would survive. So we have to be very patient as ECMO programs to let that an adequate time period go, because the adult lung, under lung protective strategies, does take time to recuperate, and every patient's going to be different. So I think that's a really good cautionary tale to tell throughout this experience.
Yeah, I think also that we will see with the reports that are coming out that we just are going to accept the fact that ECMO is going to take longer, that we can put patients on ECMO longer, and that we have to find ways to do that with regards to anticoagulation or change out of systems,
Right.
In the early days of ICU, I remember, and I'm not saying I'm very old, but we didn't have oxygen, we didn't have ventilators for everyone, We just had to decide as well sometimes we put someone on the ventilator for a few hours, and then we switched the ventilator to another patient, because there was simply no ventilators for every patient. And I remember that we had one oxygenation saturation sensor for 25 patients, and then we just did our tour around the ICU. So maybe there will be ECMO ICUs where there's an ECMO for every patient, to avoid putting them on a ventilator. So who knows?
It was an interesting topic yesterday from Luc Puis. How has your blood supply been affected by the COVID? And Bruce basically brought up a good point where he feels like that blood transfusion from a COVID patient actually can get COVID from a transfusion. And how we only have like a 3-day blood supply in our country, whereas the Europeans seem to have a much broader blood supply in their areas.
I'm not sure if I can answer that. Yeah, I don't know if there's a difference between Europe and the US regarding the blood supply. I've heard that there was that they were on the edge of having a shortage, but I don't know if they actually had a shortage, because we have, stopped operating on patients as well. So yeah, I couldn't say anything meaningful about that. Sorry.
Have you heard the terminology long haulers syndrome, Luc,
Yeah.
associated with COVID?
Hmm.
What's your knowledge of that?
Well, I know and I think everybody knows that some patients have long-term um, effects of COVID. And I remember I volunteered in a vaccination center, and there was this young lady. She was, I think, 23 or something, and she came to get her vaccination. And I'm talking like a few weeks ago, so that was in March, I think. And she told me that she got infected in March 2020, and it was only a few weeks, 2 or 3 weeks, that she hadn't felt any symptoms anymore, and she was on anticoagulants the whole time. And of course, she was afraid that with AstraZeneca she would get sick again, or have complications. And I don't know what the outcome was, but it's not always. It's very subtle. The long haulers, they just have like, it's not that they're sick all the time and at home, but they're just debilitated by, they have little bit shortness of breath. It's like, you have a strained shoulder and it's always nagging you, and it's always there, but it's not, you can still function, but it's still there. And I think that in the long term, it's like when you smoke, you have lesser years to live, and if you have gotten COVID, you will probably, some patients will also have a stronger reaction to other diseases. And I think registries like the genomic trial can maybe shed some light on these long haulers. But it really is a problem, I think, for many patients.
Yeah, I think that it was like 18 to 20% had long hauler syndrome. And I actually know somebody very well that's been in and out of the hospital. They'll start feeling better, and all of a sudden the peripheral or the limb paralysis will set in, and they have to go back in for another, plasma,
Yeah.
exchange.
Wow.
And yeah, so I think, these particular patients, their neuropathies, both, cerebral, limb, exhaustion, it's just like a cycle. It comes and go. It's very debilitating. You mentioned Dr. Kwan's lecture sometime back on the AMSECT webinar, and I remember him saying for patients that go on ECMO, VV ECMO, COVID patients, that their weaning process tends to take a little longer. They tend to be a little bit more conservative with their weaning process, because they've had a number of COVID patients come off ECMO only to have to go back on or deteriorate after that time. Do you remember that statement, or do you want to elaborate on that?
Yeah, well, I think the patients that are being put on ECMO are like really they come from a long road of ventilation and barotrauma, as you said, and they just have a longer, they also are longer on ECMO, so they need a really long time to get weaned. I can surely imagine that. We sometimes have patients that you would be like, if they would be, for example, from a drowning or something, or a less severe disease, you would be like, why is this patient still on ECMO? Very low tidal volume, very low gas flows, just enough. But if you switch it off, then they just completely crash. So yeah, that's certainly something that we see here. Yeah.
So the
That
reason
they just need that little bits of support to go through. Yeah.
So the reason I mentioned that is in typical ARDS patients, it seems like we were able to wean a little bit more aggressively um, when it's time. But for the COVID patients, the clinicians are tired. They're saying, well, man, we're going to miss this window. We probably need to come off sooner than later. I don't know why they're waiting for a couple more days. Well, now we see some ample evidence to show that maybe staying on ECMO just a little bit longer, despite the X-ray looking better and gas exchange looking well, it might be a valid point with these COVID patients because of this slipping backwards sequelae that we're seeing in many of these patients. I'd love to get off ECMO when the time's right as well, but it looks like there's some backsliding with these type of with this type of disease. I remember you made the comment about it's not when we'll have to do this again for a pandemic. It's not if, it's when. We said the same thing with H1N1.
Yeah, but that's exactly what it is. And with regards to the weaning, and I think we're almost out of time, but with regards to the weaning, you also have to remember that there's especially in the first wave, we had a lot of patients coming in and they were standing upright. They were not feeling bad, but then it turned out they had saturation of 85 and their lungs were white and they just walked in the hospital. It's a very strange, unpredictable disease. And especially in the first wave, we saw patients that had a really bad CT scan, and that was the only symptom that they had. Like their lungs looked terrible, but they felt okay, So it's a very strange disease.
Luke, we have time for one more question. Brian, would you like to?
Yeah, I'm just going to try to summarize, some of the questions that I see online, but there's kind of a lot of questions revolving around just general differences between the US and Europe. Are you aware of anything else, that you're doing differently over there than what we're doing in the US? You covered some of this with the ELSO Euro statistics. Is there anything else that's different or you see it as better that they're doing in Europe that we're not doing over here?
Yeah, I wouldn't know, but I think from what I've heard from people speaking from the US, there's a lot of alternative anticoagulation used. More bivalirudin use in the US. Like I heard from some centers in New York and that they just switched to bivalirudin. Like we're not doing heparin anymore, and I think that will also be the future of anticoagulation. Just need something different, but for the rest, I couldn't tell you if there's any other difference. I think the treatment of ARDS is pretty much the same everywhere, and yeah, I wouldn't know. We only use centrifugal pumps. I don't know if roller pumps are still used in the US. You should tell me.
Not for adults, it's mostly centrifugal, but certainly in the neonates and the pediatrics, there's a fair amount of roller pumps that are still used, but not so much for adults, I would say, with the new, the better technology that has come out in the last few years with centrifugal pumps.
Yeah, okay. Good to know.
Well, Luc, thank you so much. We hope you enjoy your friends meeting up later in Belgium. So have a great one, and thank you again. Very informative.
Thank you. It was my pleasure. Thank you.
Thank you.